Before I start this video, I would like to take a consent from my patient. Can you tell me your name
Because
and your date of birth?
June 25th, 1985.
Okay. Do you allow me to post this video as unlisted on YouTube for my instructors viewing?
Yes, I do allow.
Okay. So as soon as I'm greeting my patient and I'm talking to the patient, I'm assessing the level of consciousness. So when I'm introducing myself and whatever response I get from the patient, from there we can easily figure out if there is any marked deficits or any confusion. So hi, my name is Neema Pingal and I'm a nurse practitioner student, and I would do your neuro assessment today. So here I can see that my patient is awake, alert, cooperative. He knows what's going on in the surrounding. So that was his level of consciousness. For orientation, I'll ask few questions to my patient. So can you verify your name for me?
Because
And can you tell me which month and year is this?
this is August 2020.
Okay. And do you know which place is this?
House, I mean,
Okay. Yeah, that's clinic, he said. And then do you know what brings you to the clinic today?
just regular follow-up.
Okay, so that was the situation, like what was bringing the patient to the clinic today. And when I was talking to my patient, I saw that the speech of my patient is clear and articulate and making sense whatever he's talking. Now I'll go ahead and I'll check for the memory, recent and remote memory. So sir, I will tell you to remember these three words, and then I'll ask you later on. Apple, orange and red.
Apple, orange, and
Okay. So now, can you tell me who was the first president of United States?
George Washington.
Okay, so that was a remote memory. Um, Now for reasoning, um, so what would you do if you find a driver's license on the street?
Give it to police officer or just mail it to them.
Okay, mail it to them back or give it to the police officer. Okay, so that was the reasoning. Now can you repeat those words which I asked you to remember?
Red, orange, and
Okay. Apple.
orange apple.
Okay, orange apple and what did you
Red,
say?
orange apple.
Thank you. So, okay. After this, I will go ahead and I will check for my patient's cranial nerves. So I'll start with olfactory, which is the first cranial nerve. So here I will ask my patient to close one nostril, each nares, and I'll give you something to smell, and you have to tell me what it is. Okay? Can you close your eyes for me? And close your one nostril.
It's a toothpaste.
Okay, can you close this one?
Toothpaste.
Okay. So that was a toothpaste. And now I'll check a second, which is optic nerve. So I'll start with Daniel's chart. So can you close your left eye? Okay. Can you read the last line?
LTFPH.
Okay. Now can you close your this eye? Can you read the last line?
LTFPH.
Okay. So and now with both the eyes.
LTFPH.
Okay. So this was his vision, which was 2020. And then in general setting, it is at 20 feet, but with this, you can keep it at 6 feet with a small chart. Now I'll go ahead and I'll check the visual confrontation of my patient. Here I will ask my patient to close one eye and I'll close my one eye so that we have our same field of vision. Okay. We'll just close the opposite eyes and I'll wiggle the finger and you have to tell me wherever you see it.
I see. I see. I see. I see.
Okay. Close this eye now.
I see. I see. I see. I see.
Okay. Now with both the eyes.
Yes, I see.
So me and my patient both should see the finger at the same time. Now I'm gonna go ahead and I'll check the fundoscopy. So with my ophthalmoscope, I'll dim the lights and make sure I adjust the diopters as per my vision, if there is any defect in my vision. And then with my right hand, my right eye, and my patient's right eye, I'll check his retina. Can you take out your glasses for me? Look straight. Okay. Now I'll do the same thing with the left eye. Okay. So here I was checking for the red reflex. I saw my retina is intact in both the eyes. There was no nicking, no copper wiring, there was no hemorrhage or no cotton wool spots. The curve disc ratio was 1 is to 3. And I would do the same with the left eye, left hand, my left eye, and my patient's left eye. That way, I don't bump into my patient. And whenever I see, I'll make sure, as I told in my last video about the safety, that I'll keep the hands here and I'll hold this ophthalmoscope like this. Uh, Now, the third nerve is oculomotor. So, as we know that most of the extraocular muscles are controlled by the cranial nerve 3, which is oculomotor, except for trochlear 4, which provides no um, the the cranial nerve 4 supplies superior oblique. So we have to check for medial and downwards for trochlear, which is 4, and for 6, which is abducens, it supplies the lateral. So I have to see if my patient's eyes are medially. So I told about 3, cranial nerve 4 is trochlear, and 6 is abducens, which supplies the lateral. Now I'll tell my patient to follow this pen tip in an H pattern, just with your eyes. You have to just follow. Okay. So my patients, all the cardinal gazes were fine. When I was checking for the cardinal gazes, I was even looking for the nystagmus, which is like a jerking movement of the eyes. And in my patient, there was no nystagmus. Now I'm gonna do a direct and a consensual light reflex. Can you look straight? Can you take out your eyeglasses? So in direct, whenever I shine the light in one eye, the pupil will constrict, and simultaneously the other eye pupil should also constrict. That this is direct when I'm shining the light directly, and the consensual is when the other eye pupil constricts. Constrict. So that when I see that both the pupils are constricting directly and simultaneously, so that is direct and consensual light reflex. Now I'm gonna check my patient's fifth cranial nerve, that is trigeminal. So it has both motor and sensory function. So for the sensory function, I'll tell my patient to close the eyes, and you have to tell me, sir, my patient has already closed eyes. You have to tell me if the touch you feel is sharp or dull, and I'll check on the forehead, cheek, and chin.
Dull,
Okay.
dull,
So and now,
splitting,
okay,
sharp,
sure.
sharp.
Okay. So that was the sensory part of, he guessed correctly that it was a dull touch and a sharp touch. Now I'll go ahead and I'll check my patient's motor sensation. So for that he has to clench his teeth. Clench your teeth. Clench your teeth. Try to open your jaw. Okay. So with clenching the teeth, I palpated his temporal and his mandibular, and I could feel the pressure when he was clenching the teeth. So that means his motor is intact when I was palpating the jaw. Now I'm gonna go ahead and check. Sixth is trochlear. Now I'll go ahead and I'll check my patient's facial. So for my facial, I'll tell my patient to uh, raise the eyebrows. So can you look there? Can you raise your eyebrows? Can you puff your cheeks? Can you smile? And can you wrinkle your eyebrows? means his seventh facial nerve is intact, and I was looking for the symmetry. Mainly here is symmetry. Now the eighth one is vestibulocochlear or acoustic. So that is hearing. So I'll go ahead and I'll whisper something in my patient's ear. I know it says about the tick of the clock, but I don't have a ticking clock like a small clock. So I'll whisper. I'll stand again one hand, and then can you close your ear? Can you close your one ear? Okay.
Apple.
Okay, close your that ear.
Cupcake.
Okay. So the ear which was closed was not tested. So which one is open ear? I was testing that. Now I'll go ahead and I'll check the tuning fork, the Weber's test. So for that, sir, I'll strike the I'll keep the tuning fork on the center of your head or here, and then you have to tell me if the sound is equal in both the ears or it's lateralizing to one side. Same in both the ears. Okay. So that was the Weber's test, and for the Rennie's test, I'll keep it on your back of your ear, that is mastoid bone, and whenever you do not hear the voice here, you have to tell me that okay, now I do not hear the voice, and then I'll bring it here, and then you have to tell me if you hear there or not.
Okay. I hear.
Okay, and then I'll do the same way in the other ear. So this was a positive for so that means for the Weber's test there was no lateralization, and this was Rennie's test. For the Rennie's test, for my patient the air conduction is greater than the bone conduction, because the bone, when he didn't hear it, I brought it here, which was air conduction, and he could still hear it. So that was the eighth one. Now the ninth one is glossopharyngeal. For that, I'll ask my patient to open his mouth wide. And before I do this, 1 minute, sir, I'll check glossopharyngeal and vagus, 10th one, both together. So can you open your mouth for me? And I'm checking for the uvula, which should be midline and in the center. There is no swelling. And when I ask my patient to yawn, can you yawn for me? So when my patients yawn, I'll see the soft palate goes up. I don't have a tongue depressor, but when I put the tongue depressor inside his gag reflex, I'm checking for the gag reflex. I won't go very deep inside, but like a little bit inside, and the patient should like have a gag reflex positive. So that was 9th and 10th. And even I'll check for the swallowing. Can you swallow for me? So the swallowing is also positive. So that was 9th and 10th, glossopharyngeal and vagus. Now the 11th is spinal accessory. Here I will check for two, sternocleidomastoid muscle and trapezius. So for to check for the trapezius strength, I'll tell my patient to shrug the shoulders against the resistance. Can you shrug your shoulders? Good. Now can you look the other? Okay. Look this side and try to. Okay, sorry. Try to push. Good. Okay. Now look here and try to look here at me. Okay. So against the resistance, that was the sternocleidomastoid muscle. And the last one, 12th, is hypoglossal. That supplies the tongue. For that, I'll ask my patient to stick out the tongue. And I'm checking if the tongue is in the midline. There is no atrophy or any fasciculations. I'll ask the patient to move the tongue side to side and see if it's moving properly. So the tongue is fine. So that was 12th nerve. Now I'll go ahead and I'll check for the cerebellum. So for that, it's all kind of gait I'll tell my patient to do. So just to start with normal walking. Sir, can you walk for me? And I'll check the gait. It should be regular. Okay. Can you walk again there? Okay. So I'm checking for the balance, his hand movement, which should coordinate. Okay. Now, can you do tandem walking? Means touch your tip of the toe to the heel. Okay. Here again, I'm checking if there is any loss of balance or not, which he's doing correctly. Now, can you walk on your heels?
Heel.
Yes. again checking for the balance here. Now can you walk on your toes? Okay, again checking for the balance here on the toes. Now I'm gonna go ahead and do the Romberg's test. So Romberg's test is done for the position of sense. Um, so if there is any cerebellar disorder like any lesion or any cerebellar stroke, so patient won't have that balance maintained. So for Romberg's test, I ask my patient to close the eyes and touch your feet close to each other. Bring your feet close to each other, and just you have to stand there for 30 to 60 seconds, and with the eyes closed, with the feet uh, together. If my patient starts a little bit of swaying is normal, but if he literally loses his balance, that means there is something abnormality. Can you close your eyes? And I'll check for 30 to 60 seconds here. Okay, now I'm gonna check for the pronator drift. Sir, can you keep your hands like this? Yeah, straight. Okay, and then again close your eyes. Again, I'll tell my patient to wait for 30 to 60 seconds, and if there is pronator drift positive, one of the hand will start drifting down. And just in case if I hit my patient's hand, it should again come back in a normal position up. So his pronator drift is fine. Okay, you can sit back, sir. Now I'll check for the rapid alternating movement. For rapid alternating movement, I'll ask my patient to, sir, you have to touch my finger and then touch your nose, okay? And I'll keep moving this. Okay, now this shows that like a rapid alternating movement. That means my patient's coordination is fine, and he don't have any difficulty, like focusing or coordinating with my finger and his nose. Now I'll go ahead and I'll check for the sensory system. So to start with the sensory system, I'll start with the joint position sense. For that, I will how to do this. Okay, okay, yeah. So I will grasp my patient's big toe. First, I'll move it aside from the rest of the toe, and then I'll move it up and I'll move it down. Okay. Now I tell my patient to close the eyes, and sir, wherever I move it, you have to tell me like if I'm moving it up, down.
Okay.
Okay.
Down. Up.
Okay. So that was the joint position sense. I mean, with his closed eyes, also the patient should be able to feel the sensation where we are moving it. The second one I'm gonna do is 2-point discrimination. So for 2-point discrimination, I have an open end of my paper clip. Usually I shouldn't say this in front of the patient, and whenever he closes the eyes, I will poke it on the upper extremities and the lower extremities. So for the upper extremities, the width is fine, but for the lower extremities, we should try that if we have to like not very sharp push pins or any two pins, because for the lower extremity you need a little bit more width for the patient to feel it. Because I think the sensation is a little bit less in lower compared to upper. So sir, close your eyes and you have to tell me if you are feeling one prick or two prick. Okay.
Okay. Two.
Okay.
Two.
Okay. So.
Two. Two.
Okay, good. So he felt one when I did one. Now I'm doing it for the lower extremity. He's just saying one because, as I told, the width should be a little bit more.
Two. Two.
Okay. So that was the 2-point discrimination. Now I'm gonna go ahead and do the graphesthesia. In that, with any blunt object, I'll write something on my patient's palm, and he should be able to tell me that what I'm writing with the eyes closed.
Three.
Good.
0.
Okay. So that was graphesthesia. So his sensations are fine with the eyes closed. Now again, I'll check for the upper and the lower extremity, the tactile sensation. So for the tactile sensation, I'll again have my patient in the upper extremity. He should tell me that if it's a dull touch or a sharp touch, and same I'll do with the lower extremity, dull touch or sharp touch. So let's start with the upper extremity, sir. So close your eyes.
Light touch.
Okay.
Sharp.
Okay.
Dull. Sharp.
Okay. So that means his tactile sensations are intact. Now for the lower extremity, same thing. Close your eyes.
Dull. Sharp. Dull. Sharp.
Okay. So that is dull and sharp, means the tactile sensation is intact. Now I'll go ahead and do a vibration test. So for vibration test, actually you need a as per our book says, you need a 128 hertz tuning fork. But I have this and I'll consider it a 128 tuning fork. And I'll again strike this tuning fork. I'll keep it on his distal interpharyngeal joint of the finger, and then again I'll keep it on the distal interpharyngeal joint of his toe, big toe, and he should just be able to tell me if he's feeling the sensation, vibration or not. Can you feel the vibration?
Yes. Yes,
Okay. So my patient says that he feels the vibration even on the big toe and on the distal interpharyngeal joint. That means his vibration is, he could feel the vibration sensation. Now I'll go ahead and I'll do the motor system. So for motor systems, I'll check for the muscle strength, the equal, like if the strength is equal or not, if it is same on both the sides or not, I'll compare it. So I'll start with the upper extremity. For the upper extremity, I'll start with deltoid. I'll do all three: deltoid, triceps and biceps. So let's start with first deltoid. So sir, can you stretch your hands? Push against the resistance. Okay, good. So I can see it is 5 out of 5 as we graded. Um, Now for his biceps. Okay. So for the biceps, he has to push against, which is positive, and I'll do it both on both the hands. So I know the symmetry. I can compare like if this any of one side is weaker or not. Now for the triceps. For the triceps, okay, push again. Okay, good. And then this was a triceps that he was moving it against the resistance. And now I'll go ahead and I'll check for his finger, his strength of the fingers. So can you, hand. So I can see that he is grasping both of my hands equally. Like, because I've seen in many stroke patients, if they have stroke on one side, the grasp is very, very light compared to the other one. Now for the fingers, so can you widen your fingers like this? Okay. And when I try to squeeze your fingers, you have to resist me. Okay, good. So I can feel the resistance. So that was a finger strength. Now I'll go ahead and I'll check the lower extremity. I'll check for the quads, hamstring, hip abductor and hip adductor. So for quads and hamstring, I'll tell my patients, the patient is sitting like this, his knees are flexed. Can you push against my hand, sir? Okay, so this is your quads. And then can you push as if you're gas pedaling down? Okay, good. So this was his hamstring, or his knees. And then now for the hip abductor and hip adductor. So can you lay down for me? And I always am doing side to side so I can compare. So yeah, perfect. This is perfect. So now you have to try. I'll try to open your hips and you have to resist it. No, you have to resist.
Okay.
Okay. So he was resisting like this. Abductor is fine. Now can you open your, and when I try to close it, you have to resist it. Okay. So even that is positive. So that was hip abductor and hip adductor. Now I'll go ahead and I'll check, and I always check side both together. In this you have to always check both together. Now I'll go ahead and I'll check for refluxes. So for refluxes, we always check for deep tendon refluxes. So I'll start with, again there is a grading of how we do it. Like if I think it's 4, it's very brisk. That means it's very hyperactive and clonus. If it's 3, then it's a little brisker, like average. 2 is considered normal. 1 is like diminished and like a little diminished, and 0 means it's absent. the deep tendon reflexes are absent. So I'll go ahead and I'll start with bicep, which is C5 and C6. So for my biceps, I'll ask my patient to like flex the elbow a little, and his hands should be in a pronator position, and I'll hold it. So I'll hold my patient's hand like this, and I'll find for the brachial tendon here. And when I find for the brachial tendon, uh, okay, perfect. So his hand should be a little flexed and relaxed. And I found the brachial tendon, and whenever I strike on his brachial tendon, the hand should get flexed. The biceps should contract, and the hand should get and it should get flexed. Okay, so like this inside, and the patient shouldn't be aware of this. Uh, I mean, if the patient is aware, then obviously the reflexes won't be positive. Now I'll go ahead and I'll check for the triceps of my patient. So I'll again for the biceps, I was observing for the flexion of the elbow and the contraction of the biceps. Now I'll go ahead and I'll do a triceps, which is C6 and C7. Now again for the triceps, I'll tell my patient to flex the arm. You can either do it in the supine or lying position. I'll do it in the sitting or lying position. I'll do in the sitting position, and I'll ask my patient to flex and bring the palm a little closer towards the chest. And so for this, I'll hold my patient here, and then I will again I'll hold my patient here, and then I'll check for his triceps. So for biceps I did here, triceps I'll do here. And again, for this I have to check for extension for the tricep and contracture of the tricep and extension of his elbow. So I should find a point. Okay, so it should come outside a little for that. Now biceps is done, triceps is done. Now patellar. So for the patellar, again this is a good position when my patient is sitting. So below this there is a small notch, and I'll just tell my patients legs should be sitting, and he hanging legs, mainly we do it hanging. Just a minute, I'll try to do it a little bit down. Okay, I think this is good. You can see it. Yeah. Okay. So the hanging is a little bit better in here, and for patellar is L2, L3, and L4. And whenever I strike the hammer, his knees are flexed, and I'll briskly tap the patellar tendon just below this bone, and I'll look for the contraction of the quadriceps, and again here there should be the extension of the knee. So it should come outside, it should extend. So that was patellar, and now I'm gonna go ahead and do Achilles. So Achilles is S1. So I know I shouldn't keep it like this, but for the video sake, I'll keep my patient's foot like this. So for Achilles, you have to tell the patient to dorsally, like partially dorsiflex his foot, and you have to check for the flexion, plantar flexion of the tendon. So for my Achilles, I'll hold it here. So it should. So I'm looking for the plantar flexion of the tendon, and the foot should be dorsiflexed for that. And lastly, now I'm gonna check for the Babinski's reflex plantar, which is L5 and S1. For that, again, I'll use any blunt side, and then I'll start from the sole, and then I go all the way medially inside. Usually all the toes should plantar flex like this. But if you see the dorsiflexion of the big toe, that means there is some CNS lesion. So I'll start medially. So all that, oh, wait. Yeah. So how there is plantar flexion, there shouldn't be any fanning of the big toe, which is CNS lesion. So that concludes my video. Thank you so much.